The standard approach to risk stratification in follicular lymphoma is to use what's called the Flippy Score, which stands for Follicular Lymphoma International Prognostic Index. And the Flippy Score is a score of 5 clinical points that can be assessed easily for any individual patient with follicular lymphoma. So that is an old prognostic indicator, but it still can be used in this day and age to assess a person with follicular lymphoma's risk for how well they will or will not do in the future. The other factor of follicular lymphoma that affects prognosis significantly is the grade. So follicular lymphoma is graded based on the number of large versus small cells that are present in the biopsy tissue. And so grades 1, 2, and 3A are generally lumped together as what we think of as follicular lymphoma, the more indolent variety of follicular lymphoma. Whereas grade 3B, which has an increased number of large malignant cells in the biopsy, generally is more aggressive and behaves more along the lines of diffuse large B-cell lymphoma and is treated accordingly. So I think in modern practice, most physicians still use the Flippy score as sort of the main way to risk stratify. Another score that has been developed is the Flippy 2 score, which incorporates some other factors, including the bone marrow biopsy and the beta-2 microglobulin. I would say that the Flippy 2 score is probably used less commonly because many times the bone marrow is thought not to be absolutely necessary when you're staging a patient. And so probably it's less common for doctors to actually calculate a Flippy 2 score. The outcomes for patients with follicular lymphoma can be quite variable. For example, there are patients with follicular lymphoma who never need treatment at all. And there are other patients who need treatment from the moment they walk in the door. The outcome is somewhat related to stage, but most patients with follicular lymphoma have advanced stage 3 or 4 disease at the time of presentation. We generally divide those patients with advanced stage into 2 groups, either a high tumor burden group or a low tumor burden group. And in the low tumor burden group, we generally advise a watch and wait strategy, whereas the high tumor burden patients are having symptoms, very large bulky lymph nodes or pleural effusions or cytopenias from marrow involvement. And so I think many patients who present have low tumor burden but advanced stage disease. And in those patients, I like to keep in mind the following statistics that we know from trials, which are that about 50% of those patients will need treatment within the next 3 years, but that about 10 to 20% of those patients can still go 10 years and not even need treatment. And that really points to the variability of the natural history of the disease, that there are patients who can go 10 or more years and still not need treatment. The majority of patients will need treatment, but again, there are those lucky patients who can go a long time even without needing treatment. Furthermore, after treatment is begun in patients who do need treatment, there is, of course, variability in outcome. We know that patients whose disease relapses within the first 2 years of initiating treatment have a less favorable outcome and a median survival on the order of 5 years, whereas patients whose disease does not relapse within the first 2 years of their initiation of treatment have a more favorable outcome and may have a lifespan that is quite close to that of someone their age who does not have follicular lymphoma. And so, again, pointing to quite different variability in outcome for different patients with the disease. Follicular lymphoma is not unique in that way. There's variability in outcome in virtually every cancer, and especially the blood cancers that I treat, and that's true of multiple myeloma, diffuse large B-cell lymphoma, et cetera. So, in my opinion, risk scores really are not so much used to determine the best approach to therapy. I think they're really used more to help patients understand their prognosis and how they're likely to do. But in terms of choosing an actual therapy, my choice of a patient therapy doesn't depend so much on their Flippy score or other risk stratification, modality that I'm using. It's, do they need treatment or not based on their clinical presentation, and then I sort of choose the treatment independent of their prognostic score from the start. As I said, about 3/4 of patients who present with follicular lymphoma have advanced stage disease, that is stage 3 or 4 disease, and not all of them need treatment right away. In fact, many of them don't. So in general, the field has evolved to think of these patients as having either high tumor burden or low tumor burden disease. And in general, we think that the optimal time to initiate therapy is when a patient reaches that high tumor burden state. So if a patient who walks in the door has a high tumor burden state, then that person probably needs treatment. Whereas if the patient walking in the door has a low tumor burden state, we generally will advise a watch and wait strategy until that patient hits the high tumor burden state. What is high tumor burden? Generally involves the degree of cancer in their body and whether that cancer is a threat to their organ function or whether it's causing them any symptoms. That might include heavy bone marrow involvement causing low blood counts. It might mean that the patient has a pleural effusion that's causing them to be short of breath or need fluid drain from their lung. That would be an indication to start treatment. It may be that there's a bulky lymph node that's starting to press on the ureter and therefore about to lead to some kidney dysfunction. And so that would be a reason to start treatment. There are criteria called the Gelf Criteria from a French group that also use lymph node sizes. Gelf node criteria include any lymph node measuring 7 centimeters or more in size, or 3 or more lymph nodes measuring 3 centimeters or more in size. And so some people will use those criteria as well as a decision point to initiate therapy.